Hi there. My name is John Knight. I am a physical therapist here at Altius Physical Therapy and Wellness. We are today going to be introducing our new preventative healthcare program called the Vital Life program. We're really excited. This has been a work in progress for the last 2 years to bring together the last like 20 to 50 years of evidence surrounding preventative healthcare. So thank you for your interest. If you do have any questions, you are interested in the program, you can reach out to me at 970-829-4804, extension 103, or you can simply email me at john@altiuspt.com. Would love to hear from you. Even if you're just interested or you have a couple questions on the presentation, I'm more than happy to nerd out and talk about any of this stuff. So what we're going to talk about today first is what are we missing in medicine? Why is a program like this necessary in today's field? Our mission statement, what are we trying to accomplish with our program? The big thing, why does this matter individually to me? A little bit about the program, and then the second half of the presentation, we're going to talk about the science of chronic disease prevention, but then kind of bring it all back at the end there. It's a big picture. So there's a lot of things that we're missing in medicine, and we could probably spend like an entire lecture series going over this. But one of the big problems as it relates to chronic disease prevention is that we don't start treating a disease until it's critical enough. So take A1C percentage. If you get blood work done and they do an A1C percentage test and you are at 6.4% at your A1C, the critical cutoff for being diagnosed with diabetes is 6.5%. So if you're just below that threshold, that might not be enough in order for you to get the medications and the prescriptions to start treating and managing this condition. Now, that doesn't mean that diabetes or metabolic disease hasn't already started to take hold. It just means that our medical system says that it's not critical enough. So that's a huge issue because medicine and especially these chronic diseases are not a black and white diagnosis. It's not you have it or you don't. It's more of a spectrum of the severity of these different conditions. So that's a huge issue that we instead want to start treating some of the root underlying causes once we see these initial signs of these diseases taking place. The second is that nobody teaches us how to do these things. It's not like there's a high school class on like how do you eat, how do you move, how do you take care of your health and navigate these really complex medical processes. So this program is designed to educate you on your body and your body's needs and then give you a very individualized approach. None of this is cookie cutter. I'm not giving the same interventions for different people. All of this is based on what is your body trying to tell us? What are the things that we need to prioritize first? And it's really needed. So 3 out of every 4 adults in America are managing some form of a chronic disease, and which is just a staggering number to consider. Once we get up to retirement age and we're 65 years and older, 9 out of every 10 adults have some form of a chronic disease. And a lot of these things we kind of just push off as like, oh yeah, everybody has these conditions. These are disease processes that if we had managed the root causes earlier, might not have been so severe or so limiting. We might have even, prevented them from happening in the first place. So there's a huge need to start proactively managing the development of these different conditions. And because it's so prevalent, our country and the United States spends an insane amount of money trying to manage and not prevent, but manage these chronic diseases. Additionally, what this means is that once they've really started to manifest and limit your function, especially as we get older into our late 60s and early 70s, we spend the majority of our retirement in and out of healthcare visits and spending lots of money on healthcare related expenses. And all the while, private insurance companies like United Healthcare are denying 1 out of every 3 claims. So the burden of managing your health is increasingly shifting onto the patient's shoulders as opposed to the medical system. But the medical system is also taking a huge hit too. In the United States, we spend on average $15,000 every single year per capita on our citizens' health. The next closest industrialized nation spends $5,000 less per capita than we do. And our numbers are not pretty, right? We spend this huge number or this huge amount of money on managing our citizens' healthcare, but 3 out of every 4 adults still has one of these chronic conditions. And this is more than double what the average industrialized nation is spending. So the average is about like a little under $8,000. We're almost double that per capita every single year. So something needs to be done, not just for the sake of our clients and our individuals' patients' health, but also just for the sake of trying to shift the approach here in medicine to a more proactive approach. So the first thing is, when I'm trying to get healthcare information, where am I getting it from? It's really easy in this social media day and age to like see somebody online that has the perfect physique that I want to find when I look at the mirror, right? But what are they trying to sell me? What's their motive, right? And I've heard things like, is red light therapy going to cure my pain? Yeah, maybe it's going to help, but big picture, is it going to treat all these different conditions that I'm managing, right? Or GLP-1s for weight loss, awesome new drug, but is this a safe and effective way for long-term and chronic disease prevention? There's a lot of people that are considering taking a GLP-1 like Ozempic or Wegovy short-term, cutting a few pounds and then going off it and kind of going in and out. So there's a lot of different perspectives on medicine and preventative healthcare out there. But ultimately, trust people that have devoted their careers to understanding the science of medicine and chronic disease prevention. So if you are debating on who you should trust for your medical information, if somebody doesn't have a formal background in medicine, I would just raise a yellow flag, right? It doesn't mean that all people that don't have a degree in medicine shouldn't be listened to, but if it's a difference between a huge lifestyle shift and not, ultimately let's focus on people that are devoting their careers to understanding the science. All right. So what we're going to talk about today are these 4 different chronic diseases. We've got cardiovascular disease, metabolic disease, cancer, and neurodegenerative disease. And what you're going to find is that all these 4 different conditions often overlap, and having one of these increases the risk of having another one. So it's very common for people to have multiple of these conditions because they kind of feed and build off of each other. So the first one, just as a quick overview, is cardiovascular disease. This is the #1 killer globally. And unfortunately, this starts really early. So, going back to the whole, like, if a test deems something critical enough or not, we might not start to see clinical signs of cardiovascular disease. But what we know from doing autopsies is that unfortunately, this starts as early as roughly like 15 years old. So they've done autopsies of younger adults that have passed in adolescence, and they've already found evidence of fatty plaques in their coronary arteries as early as 15 years old. And cardiovascular disease is this snowball effect of like, you have a couple things start to happen and it starts to grow and grow and grow and grow. And if we don't manage it, that snowball gets larger and larger over the course of your life. When I talk about cardiovascular disease, I like to break this down into peripheral and then also central conditions. So central meaning more like related to your heart, peripheral being more related to your appendages or like your arms and your legs. The incidence or how prevalent this is in the United States is really high. So 1 out of every 2 adults has some form of cardiovascular disease. Whether this is simply just hypertension or high blood pressure, or some sort of stenosis starting to narrow your arteries, 1 out of every 2 adults has this. So the need for preventative healthcare to manage cardiovascular disease is really, really high. The second is metabolic disease. And so you might not have heard this term, but you've probably heard of diabetes. And metabolic disease is this overarching umbrella term that that takes into consideration diabetes and insulin resistance and obesity. NAFLD is non-alcoholic fatty liver disease, and then also pancreatitis. So again, metabolic disease is an umbrella term that describes different conditions that impact our ability to store, create, and then use energy in our body. And the incidence of this is 40% of Americans have some form of cardiovascular disease. And you do have to meet 3 out of 5 different criteria, but the incidence is starting to go up, especially as our diets are becoming more processed, as we're becoming more sedentary, a lot of different factors that we'll talk about that are creating this condition. Cancer, unfortunately, a lot of us are aware of what this is, but it's unregulated growth of some sort of a disease or mutated cell. You can have benign cancer where it stays in one place, or you can also have a malignant form where it unfortunately travels to other parts of your body. And when we talk about cancer, we're going to focus more on the lifestyle interventions, and you're going to find that there's almost like a 50% risk of like I can be born with certain things or more than nature, my genetic risk factors, or depending on how I live my life and the nurture side of things, I can also set myself up to either increase or decrease my risk of cancer. And while the incidence sits around 19 million Americans, the incidence or the prevalence of cancer is going down in some forms of cancer, but then there's other forms like colon cancer that are on the rise, especially in younger adults. So talk a little bit about that. And then neurodegenerative disease. Again, this is an umbrella term that describes this progressive loss of neurons or the actual cells in your nervous system, especially at the brain and the spinal cord. Again, there's a genetic and then there's also a lifestyle risk factor associated with these as well. And even though the prevalence is a little lower on this one, so about 7.2 Americans, that's from 2022, as we are living longer lives, the prevalence is starting to go up. Again, because a lot of these conditions are snowballs. They start early and then they start to progress and progress. So as we are living longer, the incidence of neurodegenerative disease is starting to rise. Okay. So what we are trying to accomplish here is we first need to identify what risk factor, what chronic diseases you might have. And we're not just focused on how long you can live, we're focused more on health span. And we'll talk about what that actually means, but it's basically like the quality of your life and the quality of your health. We are evaluating physiologic, metabolic, and orthopedic function. And then we're choosing the highest leverage opportunities for intervention. So we're not just going to throw like 40 different things at you to start doing all at once. Let's pick the ones that are most critical for your health and start there. Then we can start to grow in all the different lifestyle interventions to target these specific chronic diseases. But initially, let's start with the highest leverage options. And then second, all of this is rooted in science, right? So we've kind of combed through the research on all of this to make sure that everything that we're giving you and providing you is rooted in evidence, and it's personalized, right? This is not a cookie cutter approach. This is specifically targeted to whatever sort of chronic disease risk factors or chronic diseases you are currently managing at the moment. And ultimately, this is an investment. So this is not just a short-term treatment. This is meant to create this large shift over the course of your healthcare throughout the rest of your life. Okay. So lifespan versus health span. Lifespan is simply how long you live. And according to the Center of Disease Control, the average American will live to about 79 years old. And I believe that's from 2024. But health span is a little bit different. Health span is how long you are living without being affected by some sort of a major medical condition. And for most adults, This is about 64 years old. So after 64, 65 years old, we start to see that on average, Americans start to accumulate these medical conditions. And right around retirement, they start going in and out of different specialists and in and out of doctor's appointments. Their healthcare expenditure goes up quite a bit. So unfortunately, what this means is that on average, those remaining 15 years of your life is spent managing some form of a chronic disease. So the bulk of retirement for the average American is managing the snowball effect of their healthcare. Additionally, like I was just saying, retirement now becomes kind of this marker for increasing healthcare problems. And so my question, right, is do I want to spend the remaining 15 years of my life and my wallet managing my health? Probably not. This is probably not what you envisioned your retirement looking like. The median American, so right smack dab in the middle, half of the country is going to be more expensive, half of the country is going to be less expensive, but the median American spends about $5,500 a year out of pocket managing their health care once they're in retirement. So if you are budgeting that out for that 15-year window, once you've kind of reached the end of your health span, you can expect to spend about $81,000 out of pocket over the course of your retirement, right? So a lot of what we can do here, if we're proactive and we prevent these chronic diseases from manifesting, we're going to save our clients quite a big chunk of change at the end of the day. And I'm a visual person, so I like to see this on a graph. If we are looking at the graph here, at the very top, this would be like 100% of your health. Maybe you have like a cold here and there, or you have a little bit of back pain, but generally speaking, when you're like 50 years old, your healthcare should be pretty darn good. All right. So say we're starting at about 100%. The blue line represents the average American. So somewhere about like 64, 65, we start to see this dip in the quality of our health, right? And I would even argue it's a pretty steeper decline, and then we kind of flatten out until we get somewhere around that 79 years old, when we're eventually ready to kick the can. But it's this gradual decline starting at about 64 years old. Now, if we focused on health span and maintaining the quality of our health and through these lifestyle, diet, exercise interventions, the actual health is going to continue to improve or at least maintain. And it might start to slow down just with inevitable aging processes. But this gap between the average and the person that's really been proactive in managing their healthcare, this gap is the quality of your life, right? Is this remaining 15 years of my life managing all these health issues, or do I get to kind of, have an annual wellness checkup every once in a while, and maybe I'm on one or two medications, but that's kind of it. This gap is what represents like what do I actually want to do on my day-to-day basis. And our health is a lot better. You spend less money on it. The side benefit is you do get to live longer, right? Because we're managing less diseases, especially cardiovascular disease, that can really reduce our lifespan and increase our risk of mortality. So, I spent a little bit of time talking about retirement, but this is not just about retirement. All right. This is for the adult that maybe starts to recognize they're in their 50s and some of these things are starting to creep up. Maybe pain is limiting your fun or what you want to do, or it's limiting your work. I hear a lot of times like, wow, 40 really kicked my butt, or I have this goal of like, I want to run, but I don't know where to start. All right. So all of these things are meant to be addressed in this program. This is not just meant for people that are retired. This is meant for people that, people that are retired, but then also people that want to be a little bit more proactive. Say you're in your 30s and 40s and you want to make this shift earlier on. This will absolutely help in the middle of your life as well. Yeah. So two different scenarios here, right? On the left is kind of the ideal training for something, and on the right is I think where the majority of people, at least that I see in physical therapy, fall into. So as we get older, we'll start on the right. I will adapt to. So maybe you were a mountain biker or you're a road biker and you liked biking often. Eventually, you get to a point where you're like, yeah, you know what? I don't feel comfortable on the bike anymore, or I don't feel safe. I'm going to leave that bike at home on the wall because my back hurts or my shoulder's stiff, and this is just miserable. If you're a skier, especially in this valley, um, maybe I'm not going to join my family and my kids to go ski Vail. Maybe I'll just sit in the lodge as well because I don't feel as confident in my balance or my leg strength. Um, or if your grandkids are outside playing ball, maybe instead of joining them, I'm going to sit in the chair and watch them because I'm terrified from throwing my back out. Right. So instead of adapting and accepting this decline, what if instead we train for this, right? And regardless of how old you are, we can always train and we can always improve. Our body is adaptable. Um, so instead, what if instead I was training for this and I can drop into a single track on my mountain bike, feeling confident in my reflexes and feeling like my spine is strong and stable enough to allow me to do that, right? If I'm a skier, maybe I feel confident enough to go ski, trusting my leg strength and my knees completely, right? Or especially for the older adults, right? The difference between accepting this decline and going in and out of nursing homes or being in an independent care facility. A big goal for a lot of people in retirement is to maintain their independence, but that's something that we need to ultimately train for. Okay. So the big question is what if we instead proactively planned to manage our health and our function? So this is an analogy from one of my favorite authors, Brene Brown, above and below the line. So above the line is when we're doing these proactive things, right? We're eating enough and properly in our diet. We're getting consistent exercise. We sleep enough and we have good quality sleep, and we're taking care of our mental health. All right. Conversely, below the line is where unfortunately I think a lot of us operate, right? We eat something called the standard American diet, which the acronym is perfect, SAD, right? Um, we are in and out of stress, or maybe we're managing chronic stress with high levels of cortisol all the time. We're not getting enough sleep. We are generally sedentary, and maybe we're using some or multiple forms of coping mechanisms for our mental health. When we are above the line and we're doing these things proactively, our risk for chronic disease goes down substantially. And conversely, if we are below the line and acting as the average American does, our chronic disease risk goes up, right? And this is why 3 out of every 4 Americans have some form of chronic disease. And I would argue it's not black and white, right? Maybe we're eating well, and we're getting enough nutrition, but maybe our sleep quality is really tough, or maybe we're using coping mechanisms for our mental health, and so this would be an example where it's like let's choose the highest leverage options. If poor sleep quality is what's really raising your cortisol or increasing your risk of cardiovascular disease, let's start there and let's give you tools to managing your sleep. Um, so ultimately, our goal is to have all of our clients learn how to, and then also teach them how to stay above the line and reduce the risk of chronic disease. Okay. All right. So where we start in our program, it's a pretty comprehensive evaluation, but this is where we start. There are 2 different evaluations over the course of 2 different days. Um, of course, as a physical therapist, I want to see how you move, right? How do you operate in the real world? Are there certain movement patterns or biomechanical patterns that you are using that might predispose you to back pain or shoulder pain? Um, we do also screen for neurologic and other orthopedic conditions. Maybe you have a disc herniation that's just been lingering in your back for the last 10 years, and that's really limiting your function. So let's take a look at how you move and see if we can intervene there. We also do a 2-week blood pressure trial. Um, this this is meant to screen for hypertension and also hypotension, so high blood pressure, hyper, and low blood pressure, hypo. But when you go into a doctor's office and you are rushed to get in there, maybe you've had like 3 or 4 cups of coffee, you're talking to the healthcare provider, you didn't sit down long enough, and they take it in a way that's not perfect, you're probably going to get an altered reading, right? And so if you're like me, you go in there and your blood pressure is really high, and your doctor's like, okay, well, let's get you on some sort of an antihypertensive. Um, this 2 week blood pressure trial is really meant to see what is your blood pressure doing on a day-to-day basis, both at night and then also in the morning. So we're looking for how is your actual lifestyle impacting your blood pressure on a day-to-day basis, not just on that 1 or 2 minutes when you're in the doctor's office. We also do a pretty comprehensive metabolic test or testing. We do something called a VO2 max, which looks at our individual's aerobic capacity. This also includes lactate testing, which is a pretty unique feature of our testing. We also do resting metabolic rate, and this basically gives us an inside look into what is your daily caloric need, um, just at a baseline. So, of course, if you have a big day of hiking or something like that, like you're going to need more calories, right? But at a baseline, how many calories should you be consuming on a day-to-day basis? We also do a continuous glucose monitor test for 2 whole weeks, just looking at what is your blood sugar doing on a day-to-day basis. What's the variability? Is it going up and down all the time? Is that maybe contributing to fatigue or energy spikes? Um, and we retest these things all at the end. But looking at your blood sugar in real time is really informative to see how your diet and your movement patterns are impacting your blood sugar. And then we do a pretty comprehensive blood panel. So we're looking at metabolic markers, liver function, neurodegenerative disease risk factors, thyroid function, atherogenic markers, or your risk of developing fatty plaques in your vessels. We look at your kidney function. We look at your blood sugar from more of a long-term perspective. So doing A1C percentage tests. A1C, unfortunately, is not a routine blood draw or test. This is something that we have to seek outside of our annual wellness screen, unless you already have diagnosed diabetes. And then we also look at different sex hormones as well, and see if that's impacting your function, especially weight control and pain. With the program, this is pretty dynamic. So the top is kind of the base skeleton, but we have hired a terrific nurse practitioner, Erica, and then also a registered dietitian, Hannah Williams. So if you were like, you know what, I love this, but I also want a little bit more, or I want a medical provider that knows what specifically we're doing in this program, we have 2 in-house clinicians that work hand in hand with me, and we sit down and we discuss your specific health metrics and then also your goals and come up with a very comprehensive plan specifically for you. But these are optional add-ons if you want to dive into this a little bit deeper. This is kind of a really quick slide on like why we're actually doing these things. So, the physical therapy evaluation, am I predisposing my body to pain? Pain, of course, is going to limit my function and maybe make me a little bit more sedentary. Physical therapy, being a little biased here, but this is a much better conservative approach compared to like if my back hurts, I'm going to go in and out of surgery or manage it with cortisone injections. So let's be proactive and choose the least risky option. So physical therapy instead of other sort of coping management tactics. Planning for functional goals. So one of the first things that I ask our clients in the evaluation is, what do you want to be able to do in 5 or 10 years? If that's traveling to Europe or playing ball with your grandkids, like let's start planning for that and training for it. We do that, 2 week blood pressure panel to look at the blood pressure over the course of each day and see if that's increasing your risk of cardiovascular disease. This comprehensive metabolic testing is meant to look at how well is your body managing and handling different energy pathways and systems, and how am I storing that energy? And then again, like that very comprehensive blood panel where we're looking at sugar, cholesterol, the function of your liver and kidneys, the function of your thyroid, especially if you are post or perimenopausal, looking at these different sex hormones and seeing if there is any sort of chronic inflammation in your body that might be contributing to certain symptoms. We do look at the therogenic risk profile, so looking to see if there's fatty plaques that are starting to build up in your arteries. We do look at as well genetic risk factors that might increase your risk of dementia or Alzheimer's, and then also just some generic vitamin deficiencies, just to cover all of our bases. Okay. So that's a lot, right? And again, this is not meant to be something that you have to do every single year, but there are, especially with the genetic side of things here, a lot of these tests are things that you just have to get done once, right? We need to know what is your individual profile, right? If some of the testing comes back with, a genetic risk factor, then maybe we need to manage that a little bit more aggressively with lifestyle risk or with lifestyle intervention. But it's a lot of information to take into consideration all at once. If you are a very busy person, maybe you're raising a couple kids or your job is really stressful, we're here to work with you. We're going to pick the highest leverage options to start with first, and then we start to maybe add some layers down the road. But let's pick the things that are most impactful first. All right. So we're here to work with your life demands. I get to see you over the course of an entire year. So if you come back to me and you're like, John, this is not working for me, or I wasn't able to do this, that's fine. Let's modify your plan so that it does actually work for you, right? So that's just the evaluation. That's just what we're initially starting with. The meat of the program is these regular follow-ups. So a lot of this is to continue this ongoing conversation of whether this plan is working for you or not, and then see if we need to adapt it, right? If you come to me and you're like, this is really not working for me, that's when we change our plan in real time. Again, this is why we're seeing people over the course of a full year. At the very end of the program, though, then we do all this retesting. So we redo the blood panel, we redo the continuous glucose monitor. If there are some critical blood panel things that we need to look at, we might redo some of those. But we just want to make sure that this is working. We are making a difference. And if not, then we need to change something, or maybe we need to be a little bit more aggressive in our strategy. The other thing too is that if you did elect to work with our nurse practitioner and our dietitian, you might receive ongoing medical management as well. And all of this can be made more dynamic for you. So if you're somebody that you need maybe a little bit more kick in the butt, we can schedule out more frequent physical therapy sessions, or schedule out more frequent sessions with the RD or the nurse practitioner. But the base skeleton model is meant and built to set up so that we can consistently evaluate if what we're doing is working or if we need to change the plan. Yeah. So this is a good time to pause if you need a second, but now we're going to kind of shift into more of the science of chronic disease prevention. So we're going to focus on these top 4 chronic diseases. The first, of course, is we're going to start at cardiovascular disease. All right. So again, this is the #1 killer globally. All right. And in terms of risk factors, you're going to see that 50% of our risk factors are genetic, but 50% are also lifestyle and dietary. All right. Again, 1 in 2 American adults have some form of cardiovascular disease. So the need for developing a preventative and proactive healthcare approach is very high, and it's increasingly high. Okay. When we do our evaluation and we're looking at your risk factors, these are kind of the 2 different categories I like to break this down into. So in terms of genetics, one of the things that's gotten a lot of media attention is lipoprotein little a, or LP little a. We'll talk a little bit about this, but this is a more genetically determined risk factor. If your genetics unfortunately predispose you to higher levels of lipoprotein little a, typically above 30 milligrams per deciliter of blood, our risk of developing fatty plaques in our blood starts to go up quite substantially. And thus our risk of heart disease and a heart attack also increases with that as well. And also leads to chronic inflammation, especially in our blood vessels. We also look at cholesterol absorption. And so one of the ways that we do this is we test for campesterol and beta-cytosterol. These are two forms of cholesterol that our body can't naturally produce. And so if we do your blood work and we find that these levels are very high, again, our body can't naturally produce them. So if these levels are high, what that's telling us is that your body likes to absorb cholesterol in at a higher rate. So if you're like me and you like eating an egg or two for breakfast every morning, but our campesterol and our beta-cytosterol are really high, this might be a quick and easy thing that we do is we reduce these cholesterol heavy foods because your body might not be necessarily producing more, but maybe it's absorbing more cholesterol in, and we need to take more of a dietary approach to lowering our cholesterol in our body. Genetics can also impact kidney function and how we manage and process sodium. Um, we also look at congenital heart defects and personal fat threshold. Personal fat threshold, this is a discussion for maybe another time, but this basically relates to how much fat can I hold subcutaneously before it starts to impact my visceral organs like my liver and my pancreas. If I have a low personal fat threshold, I might be a pretty skinny individual and look good in the mirror. But if my fat threshold is low, my body might start putting these fatty or these lipid depositions into these vital organs earlier than I would expect, which would impact their function. But then the big thing is what we can change from a lifestyle perspective. So we do an assessment of your aerobic conditioning through the VO2 max and the lactate testing. We also want to help with any sort of smoking cessation. So smoking is a huge impact or risk factor for developing high blood pressure, and then also vascular inflammation or inflammation along our blood vessels. Also things like that standard American diet or the SAD, diets that include high saturated fat, high sugar, and high sodium increase our risk of developing chronic diseases. Conversely, those same diets that are typically low in fiber or plant-based foods or low in things called MUFAs and PUFAs. MUFAs are monounsaturated fatty acids and PUFAs are polyunsaturated fatty acids. The standard American diet typically follows this pattern, which lots of fat, lots of sugar, lots of sodium, low in fiber, low in plant-based foods, and low in these mono and polyunsaturated fatty acids. And then finally too, if I'm maintaining a high stress or a sedentary lifestyle, or as I get older, I start to lose muscle mass through sarcopenia, low lean muscle mass can very much also impact your risk of cardiovascular disease. So specifically around this fatty plaque buildup that I've kind of been dancing around. The medical term for this is atherosclerosis. All right. And what this means is that over time, say I have this really healthy blood vessel that's got a lot of space in the inside of the blood vessel. Once those little fatty plaques start to infiltrate what we call the intima or the inner lining of those blood vessels, what happens is now instead of this really open blood vessel, it starts to get, I'm sorry, I'm awful with the framing here, but it starts to get narrower and narrower and narrower. And so now instead of having this really open blood vessel that can supply our organs and our tissues with plenty of oxygen and blood, the space that blood has to move through starts to shrink and shrink. And so then the amount of blood going to those tissues starts to lower. And we see this in major arteries, especially the coronary arteries, and then also the carotid arteries that feed your brain. And so this individual in figure C here, unfortunately, they're starting to see this fatty plaque buildup, which means that there's less blood supply to their brain. So atherosclerosis is this process of fatty disease or like fatty plaques that build up in the blood vessels, but stenosis is the narrowing or the reduced amount of space that blood can move through. When this happens initially, it's kind of this soft plaque. And it looks a little bit like this. It's soft. It's kind of malleable. The problem with this is that it can break off, right? And so it can dislodge, and now you've got this clump of fat that's kind of moving through your circulation. And if this clump gets stuck in another artery, this can cause things like a pulmonary embolism or a stroke or a heart attack because those working tissues are now getting no blood or a very limited supply of blood and they can't function. So when these fatty plaques are new, the risk of dislodging and moving to other areas of your body is really high. If this plaque has been here for a really long time, it might start to harden or calcify. The benefit of this, and this is kind of your immune system trying to tackle and manage this fatty plaque. But the benefit is that now it's at a lower risk of dislodging. So it's hardened, it's calcified, it's not going anywhere. But the downside is that instead of having this really pliable and elastic tissue that can expand with every beat of your heart and then recoil to pump blood to those working tissues, now it's really stiff, it's calcified. And so what we see is that this blood vessel, instead of being able to expand and contract, it just kind of stays stiff like this. So the blood that's moving through it starts to kind of push against each other, right? The friction goes up, the vessel itself can't expand anymore. And so two things are happening. One, our blood pressure is going to start to rise. And then two, with all this friction of those blood cells moving through that artery and that vessel, that friction can cause clotting of those blood vessels or those blood cells as well. And that clot can then go somewhere else and cause a stroke. So while we're at a lower risk of having that fatty plaque dislodge, we are still at a higher risk of developing a clot because of the friction, and then our blood pressure starts to go up as well. In terms of the genetic side of things and what we are looking at in a blood panel, we do also test apolipoprotein B. And so this is apolipoprotein B, or ApoB, is like the skeleton backbone of all of the different bad guys in your blood that can cause these fatty plaques that we just talked about. So if our ApoB levels are starting to rise up above 80 milligrams per deciliter of blood, that means I'm at a higher risk of developing fatty plaques or atherosclerosis in my blood vessels. This is something that can move, right? We can very easily lower this number through dietary and then also lifestyle and exercise-based interventions. But especially if somebody's ApoB is staying above 80 or maybe even above 100 for a really long time, that means their risk of developing a fatty plaque is going to be elevated for a really long time. We're going to get more fatty plaques throughout our pipes. Now, Lp(a) is kind of the bad cousin to ApoB. So ApoB containing structures, things like LDL or VLDL or IDL, these things that cause the fatty plaques. ApoB is a little different than Lp(a). Lp(a) is this other chemical that binds onto ApoB containing structures. So say I have like an LDL cholesterol molecule. ApoB is this little, or Lp(a) is this little tail that attaches onto it. And the problem with Lp(a), again, this is more of a genetic thing. We all produce some form of lipoprotein a, but if I have a lot of lipoprotein a, it does a couple things. One, it sticks to the inside of our blood vessels a little bit more. So even though these ApoB containing structures will cause that, that inflammation and that plaque buildup in the inner vessels of your blood vessels, lipoprotein a is even stickier. It wants to bind to the inside of those blood vessels even more than ApoB does on its own. It's also pro-inflammatory, so it has all of these oxidized phospholipids on this tail. So again, there's my LDL molecule, the little Lp(a) protein is on the end of it. It's got these oxidized phospholipids. That's going to cause this pro-inflammatory response from our immune system. So then we get this chronic inflammation throughout our body and our blood vessels. The last thing it does too is it also inhibits blood clot breakdown. So say I did get a blood clot because I've got friction at some point in the blood cells in my vessels. LP little a is going to inhibit or decrease our body's ability to remove that blood clot. And so people that have really high concentrations of lipoprotein little a are going to have a harder time clearing that, and thus their risk of having a stroke or a pulmonary embolism or a DVT or deep vein thrombosis is going to go up substantially. So this is something that we can manage aggressively with lifestyle interventions. There are new medications out there to help lower this. But if we find that somebody has really high concentrations of lipoprotein little a, we need to be really aggressive at managing their cardiovascular disease. And especially, this is something that I want to take a look at if somebody has a family history of cardiovascular disease. So if you have a mother or a father or a couple grandparents that have died of heart disease or a heart attack because lipoprotein little a, the concentration of this is genetically determined. Even if you're really young, this is a test that you want to get done at least once in your lifetime to make sure that you're not at a higher risk of developing a stroke or cardiovascular disease. And then the last one is apolipoprotein A, and this is kind of like the good guy in this scenario. So this is a structural protein for these high density lipoproteins or the good cholesterol. And this is generally considered cardioprotective. So the more I have of this chemical or the more HDL I have, it's considered cardioprotective because it kind of helps to clear some of these fatty plaques and lipids in our blood. All right. All right, so high blood pressure and heart failure. So high blood pressure or hypertension is defined as if your blood pressure, the systolic number or the highest number is above 120. It's also defined as if the lower number, the diastolic pressure is above 80. This is an and or. So I can have high numbers in both and be categorized as hypertensive. I can also just have one of these numbers be higher than 120 or 80, and that would also be considered hypertensive. But high blood pressure basically just means that this is the resistance that my heart has to push and pump against. So if my blood pressure is starting to creep up and up and up and up, that heart has to work harder and harder every single pump. So if hypertension is left untreated for a really long time, the net result is heart failure at some point, right? And we did talk about when pressure starts to rise in our blood, there's more friction of those red blood cells. So high blood pressure also increases our risk of developing clots and then thus strokes. High blood pressure also causes inflammation in the intima or the inner lining of all those blood vessels. So hypertension and high blood pressure is a huge one. This is again why we're doing this 2-week blood panel or blood pressure panel to make sure that one and done doctor's visit might miss it. But if you're waking up every single morning and your blood pressure is really high or you're going to bed and it's really high, this is where we kind of need to start to help your heart and also all the vessels in your blood. All right. The big thing that we can do for high blood pressure and heart failure first is if you are a smoker of any form, so not just cigarettes, but any sort of smoke, or especially vapes at the moment too, that really increases our blood pressure. It's causing inflammation of these blood vessels. It's slowly going to creep that high blood pressure up, and it's making these arteries stiffer and stiffer over time. Aerobic exercise can also do a couple things to counteract this high blood pressure. It improves the elasticity or the ability of those blood vessels to expand and contract. Immediately after you exercise, you're going to release something called nitric oxide, and nitric oxide is going to dilate or open the blood vessels to allow more blood to move to working tissue. So you get an immediate benefit of doing aerobic exercise and lowering your blood pressure, and then you also get long-term benefits where we're improving the elasticity of those blood vessels. It also raises that good cholesterol molecule or the ApoB or ApoA containing molecules. So consistent aerobic exercise will raise the good cholesterol, the HDL molecules in your body. Nutrition as well, right? If we're eating a lower saturated fat diet, so saturated fats are the ones that are solid at room temperature. Think like butter and ghee or taro, for example. Things that are lower in saturated fats are going to reduce those fatty plaques in your blood vessels. Things that are lower in sugar is going to improve your metabolic conditions. Things that are higher in fiber, again, plant-based diets, and then as well things that are high in monounsaturated and polyunsaturated fatty acids are cardioprotective as well. So all of these dietary and lifestyle interventions can absolutely lower high blood pressure and then reduce your risk of heart failure. All right, so busy slide here. Put myself in the corner. But this is to go over aerobic max testing or VO2 max testing. And when we do VO2 max testing, we get this fancy number in the form of milliliters of oxygen per kilogram of body weight per minute of exercise or movement. And what we're looking for is what is the absolute hardest that your body, your cardiopulmonary or your heart and your lungs can work at. All right. So this is a maximum test. We're taking our clients to the absolute hardest point that they can work, and we're seeing how much oxygen their body is able to use at this given workload for every kilogram of body weight per minute. Sounds really fancy, but we get this number. All right. And this specifically relates to your function. So say somebody does a VO2 max test and they get a number like 20 milligram or 20 milliliters per kilogram body weight every single minute. If there's somebody that really appreciates downhill skiing and their absolute max that they can work at is 20, this means that they're not going to be able to ski. Their heart and their lungs cannot support the intensity of the demand of that exercise. Additionally, if maybe you're at 30, even though your absolute max is below this, you still might be close enough that this is too difficult for your heart and your lungs to maintain for a long time. So when we're talking about the actual numbers that we get from doing this test, this VO2 max test, where we work you as hard as we absolutely can, what I'm more interested in, how does this relate to your function? All right. So we're actually looking at like what is the max that you can work at? How much oxygen are you able to use? And then how does this tie to the goals of your function over the course of your life? All right. You'll also see things like MET or a metabolic equivalent. At rest, we spend about 3.5 milliliters of oxygen for every kilogram of body weight every minute. So we can also kind of give this on a scale of like, if I'm going for a leisurely bike ride, that's about 3.5 times as difficult as it is for me to just sit on the couch. So all of the VO2 max numbers come back to how does this implicate our function and the quality of our life. So we're going to move on here, going into metabolism and metabolic disease. So metabolism and metabolic disease, again, is this umbrella term that describes how good are we at creating, using, and storing energy. Energy is like the currency of our body. The harder we work, or the greater the intensity is of our work, the more energy we need to consume or be able to expend, right? The form of this currency in our body is adenosine triphosphate, or ATP, if you go back to your high school biology days. And this is what we actually produce when we break down carbs, when we break down fats, or when we break down proteins, right? We can either create energy with or without oxygen. So with oxygen, this is an aerobic state. Without oxygen, the term for this is an anaerobic state, or without oxygen. But both systems are working all the time, regardless of what you're doing. Just sitting here at rest, I am still using anaerobic pathways, but as I get into more higher level activities, because I need energy quicker and quicker, I'm going to start shifting to a higher prevalence or more demand on these anaerobic pathways. And we're really interested in at what level of intensity of work do you shift from more aerobic to a more predominantly anaerobic energy pathway. The benefits of aerobic metabolism is that we get a lot more energy for every molecule of glucose or sugar that we break down, but it's slower. So for every sugar molecule that we break down, if we're using oxygen-driven pathways, we're going to get about 30 to 32 ATP molecules for every molecule of sugar. but it's slow. It goes through this thing called the citric acid cycle or the Krebs cycle to produce energy, and this takes a while. Okay. Conversely, we also have the anaerobic pathways or the non-oxygen driven pathways. And this produces a lot less ATP, but it's a lot quicker. So if I'm sprinting up a hill and I need a lot of energy at one time, I'm going to use a little bit more prevalence of these anaerobic pathways because I need that energy really quick. But I get a lot less ATP for every molecule of sugar that I'm breaking down, right? So again, we're interested in seeing like at what point do you shift from more aerobically driven pathways to more anaerobically driven pathways? And that point where we kind of shift is called our lactate threshold, right? The lactate threshold is the point at which lactate production outpaces lactate clearance, meaning that if we work harder beyond this threshold, I'm producing a lot more lactate than I'm able to clear it. Lactate is the byproduct of anaerobic metabolism. So if I'm starting to shift into more higher demanding exercise, my body's going to start producing more and more lactate. And lactate accumulates over time and it starts to actually inhibit our body's ability to produce energy. So if I'm sustaining a really high blood lactate for a long time, over time, I'm not going to be able to sustain it. It's going to start impacting my body's ability to create energy. And I like using this bucket analogy to kind of break down the difference between VO2 max and lactate threshold. So on the right, there's this really big bucket. It has a capacity of 20 liters of water. That would be analogous to this VO2 max, where the max threshold that my body can work, or the absolute hardest my body can work, is really high. It's like 20 liters. But the water in it is a lot less. The water represents more of your lactate threshold, or what are you able to sustain. So if you are starting to shift into more of anaerobic driven pathways earlier on at this lower percentage of your VO2 max, you're not going to be able to sustain these higher intensities for a long duration. And so, especially for people like marathon runners, they might have a really high VO2 max, but if they're only able to use and sustain a quarter of it, their marathon pace is going to go down quite substantially. Compare this to the person on the left who has maybe a little lower VO2 max or aerobic capacity, but they're able to access a good 80% of that and sustain that for a longer duration. So while your VO2 max is important, or the hardest you can work is really important, I would argue what's more important is figuring out what can you sustain. And this is going to be impactful, like for if you are going on a 30-minute walk, you might have a really high VO2 max, but if your lactate threshold is really low, you're going to have to sit down and take multiple breaks during the course of your walk. So this functionally represents the level that you can sustain for longer durations. Okay. Another busy slide here. We're almost done. So a quick overview of insulin resistance and metabolism. So I like using the analogy of a cookie here. All right. So say I eat a cookie, my blood sugar is going to start to rise. In a healthy environment, my pancreas releases something called insulin. And insulin is going to lower my blood sugar in two different ways. One, it's going to stimulate that sugar to be turned into the more complex form of it that's more efficient for storage. This is called glycogen. And that will pull some of that sugar from my blood, redistribute it to muscles and working tissue. The other is that insulin tells the cells in my body to pull some of that sugar in. And then those cells can use that for energy. The net result after insulin has been released is that my blood sugar returns back to normal levels. So somewhere around like 100 milligrams per deciliter of blood is considered normal. Now, in a diseased or insulin resistant state, the same thing almost happens. So our blood sugar starts to go up. I just ate my cookie. My pancreas in response is going to still release insulin. But now, because maybe I really like cookies and I've been eating 4 cookies every single day for the last 20 years, now insulin's not as effective anymore. And so the liver doesn't convert sugar into glycogen. And these working cells do not pull in more sugar from my bloodstream. These cells are like, you've eaten a lot of cookies. We've got plenty of energy. I don't need any more energy. I'm not going to pull in some of that sugar from our blood. So this is what we call insulin resistant. Our body is resistant to what insulin is supposed to do. And over time, what this means is that this blood sugar stays elevated for a long time, and that causes a whole other snowball effect of medical conditions related to metabolic disease. But insulin resistance is the underlying issue associated with diabetes, especially type 2 diabetes. Um, Insulin resistance is something that we can change. So if we lower the amount of sugar in your blood through dietary interventions and also through movement before and after exercise, we can reverse insulin resistance, but it takes time. And then this is the other function of different drugs out there like GLP-1s that are lowering the glycemic load or the sugar in your blood over time. All right. What we do effectively to intervene in metabolic conditions is the first thing is we do a lot of aerobic conditioning. So we're training your body to pull in more sugar from your blood by improving mitochondria or the powerhouse of the cell, their ability to produce energy using that sugar with oxygen-driven pathways. We also improve the ability of your body to store sugar as well. So our storage capacity goes up as we are starting to put a little bit more muscle on. That's also a benefit of strength training, right? Our body is pulling sugar in from the bloodstream into working muscle tissue. So if I have more muscle because I'm strength training, that basically increases the storage capacity of my body so that my blood sugar is not staying high, but instead that's stored in those working muscle tissues. And then the last two I would say is like a lower sugar diet and things that are higher in fiber. Both of those can improve insulin resistance. And then moving before and after meals. So if I was going to eat that same cookie, if I moved beforehand, I'm telling my muscle cells like, hey, we need to start using energy. I want you to open up and start to accept some of the sugar in my blood. Um, then when I eat my cookie, those cells are already opened up and able to pull that sugar in, and so our blood sugar goes down. But then additionally, after I've already eaten my cookie, if I go out, move, and burn some of that sugar in my blood vessels or my blood sugar, then sugar goes down in response as well. Quick point on ketogenic diets is that while the glycemic load or the amount of sugar you're putting into your body does definitely go down, so it can improve insulin resistance. The issue is that a lot of these diets are really high in saturated fat, right? We're substituting a higher carb diet for a higher fat diet. And so then that increases our risk of developing these fatty plaques that we talked about earlier. So I would really recommend steering away from ketogenic diets just because of the higher saturated fat content in them. And then last two here, actually last three, we've got cancer. So we've all heard of cancer, and I kind of mentioned that there's this nature versus nurture risk factor. Metabolic disease significantly increases your risk of developing cancer. The reasons for that is that as our blood sugar is going up and our body's ability to store and utilize energy is going down because of insulin resistance, our immune system releases all these pro-inflammatory markers. So things like interleukin 6 or tumor necrosis factor A, these hormones promote DNA mutation. And so with more of them, we're finding more and more mutated cells, which again predispose the initiation or the first sort of signs of tumor. Additionally, because our pancreas is still dumping all this insulin to try to lower our blood sugar, insulin is anabolic. So as insulin resistance creeps up, our levels of insulin also increase because insulin is telling our body to absorb sugar and create new cells through like muscle hypertrophy or just grow those tissues. Insulin tells tumors that might already be present to grow more aggressively. So if you are managing cancer and you have metabolic disease and insulin resistance, Metabolic disease is creating this pro-inflammatory, pro-growth environment for those tumor cells. It's like pouring kerosene on a fire, right? It's just only making it larger and larger over time. Obesity as well, related to metabolic disease, will elevate estrogen, and estrogen levels are linked to breast and endometrial cancer. And then the last thing is metabolic dysfunction. Like I was kind of talking about, increases these things called reactive oxygen species, which further damage DNA. So when we are talking about cancer prevention, a lot of it stems from reducing your risk of metabolic disease to reduce the environment and then also the inflammatory markers in your blood and in your body. Okay. Neurodegenerative disease, this is again that progressive neural death, and it's progressive. And once this has started to set in, it keeps getting worse, unfortunately, over time. And as we're living longer and longer, the prevalence of neurologic diseases is starting to go up and up and up. And I really like this chart on the right. So throughout our entire life, in the early life, middle of your life, and later on in your life, there's a lot of different things that contribute to the risk of developing neurologic diseases. Early in life, lower education can increase our risk, but especially in the middle of the life, this is where we see the bulk of the modifiable risk factors. So things like hearing loss, high saturated fats and high LDL, those ApoB containing structures, that's a 7% risk factor for developing neurodegenerative disease later on. We also have things like depression, traumatic brain injuries, physical inactivity or sedentary lifestyles, diabetes, smoking, high blood pressure, being overweight and obesity, and then excessive alcohol use. And then later on in life, say after about 64, 65 years old, social isolation and again, maintaining a more sedentary lifestyle, more air pollution, and then also vision loss can all contribute to neurodegenerative disease. But the big take home here is that 45% of the risk factors of developing neurodegenerative conditions is modifiable. All right. So like 1 and 2, 50% of those risk factors are things that we can change and improve on in your lifestyle. So just something to consider. You know, younger adults, you might not be considering things like Parkinson's disease and Alzheimer's and metabolic, conditions, but the midlife is really where we see a lot of these modifiable lifestyle factors that will contribute to neurodegenerative disease later on in your life. All right. In terms of intervention, I'm kind of just hammering in how these lifestyle factors impact your risk of neurodegenerative disease, but exercise will maintain good blood flow to your brain, lowers your risk. Exercise also triggers something called BDNF, or brain-derived neurotrophic factor, which is like the Miracle-Gro in terms of sprouting new neurons in your brain and maintaining neuroplasticity. Exercise also improves memory. Diets that are lower in fat, low in sugar will reduce your risk of stroke. Diets that are higher in plant-based foods are anti-inflammatory, and then they also stimulate BDNF. And then also things that contain omega-3 fatty acids, so things like fish and nuts, improve memory and mental health. And then sleep is a huge one, right? If we're getting less than 7 to 8 hours of sleep every single night, our cortisol starts to spike up. That creates an inflammatory environment. Getting sufficient sleep also improves your memory. Sleep is when we remove and recycle tau proteins and amyloid plaques. And if you read into dementia and Alzheimer's, tau protein accumulation and amyloid plaque accumulation are two of the big areas of research. But sleep is naturally when we are removing and recycling these byproducts of metabolism. And then good sleep also reduces inflammation. So all of these lifestyle things are very simple ways that we can reduce your risk of neurodegenerative disease. Okay. And then the last thing in terms of chronic diseases is the case for sarcopenia. So sarcopenia is defined as age-related muscle loss, but it is a disease state. So as we get older, and we start to get a little bit more frail, right? We're losing muscle mass. And regardless of your age, I've worked with 90-year-olds that have put muscle on when they've never exercised before in their life. Regardless of your age, we can make a difference here. But in terms of the metabolic disease processes, when we have less muscle mass and volume, our storage capacity for energy and sugar starts to go down. So it's not just about how you look and your function and how well you can move, but it's also about the metabolic disease process as well. And I like to break down just like a simple format for how a lot of my clients choose to exercise and do strength training. But if I did some sort of a lower body push, like squats, I did some sort of a lower body pull, like deadlifts or hamstring curls. I did something like an upper body push and an upper body pull. Just 4 exercises. I'm going to stimulate the major muscle groups in my body and start putting on strength and mass. And the general recommendation is at least 3 days a week of strength training. 2 days a week you can get by with, but it's more maintenance, whereas 3 days or more is the stimulus that we need to build or increase our muscle volume. So big picture stuff, right? Why are we doing all this? Our goal is to lower and manage the risk of cardiovascular events. It's meant to save you money over the course of your lifetime. We don't want you to be one of those people that has to devote $81,000 over the course of your retirement to out-of-pocket healthcare expenses. We want to plan for the future of your function. So if your goal is to go travel or ski or play with your grandkids, let's start training for that early on. We want you to feel better, have more energy, more confidence when you look in the mirror, have less anxiety every single time you go into the health, to a doctor's appointment. And then ultimately be in control of your health, right? This isn't just like I go into a medical visit and I'm like, yeah, I get a surprise diagnosis that I'm not expecting. If we start targeting these things early on, we can be in control of those risk factors. But regardless of what some person with a 6-pack on social media says, there's no one size fits all, take this supplement cure to all of these diseases. This is a lifestyle approach. This is diet, exercise, movement, sleep, mental health, all of the above that we are here to put into one big plan for you. And, maybe at the end of this presentation, just consider, what do you want to be able to do in your life, right? Do I want to be able to play with my grandkids, travel, stay or maintain an independent lifestyle? Whatever it is, we need to specifically train and plan for it. And then last 2 things here. What happens on February 1st? So in January, we all go to the gym, or you go to the gym and you're like, I'm going to be this new person. I'm going to be really healthy. Gyms are packed in January. And then February 1st comes around and all of a sudden everybody's gone and gyms are empty. So we might all have these really ambitious goals of trying to be the healthiest version of ourselves, but it's a lot to handle at one time. And we need to start small. All right. So if maybe I want to exercise 150 minutes a week, eat the perfect diet, never fall off the routine, manage an active life, strength train 3 to 4 days a week, sleep 8 hours each night, raise a family, and perfectly balance a career and life, we're going to fall at some point, or we're going to falter at some point. It's not about being perfect all the time. It's about doing these small things that start to build over time and really lower our risk of chronic disease. So it's impossible to be perfect. Pick the most impactful place to start small and build from there. All right. So last thing to just leave you with here, you kind of have a choice, to put it bluntly, right? You can do nothing and hope your genetics are superior and accept the gradual decline. There are people out there that you ask them, like, what's the secret to living to 104? And they're like, oh, I had a cigarette or a shot of whiskey every single day. You can take that chance if you want to, or we can manage this risk early on, develop a plan that works specifically for you, and actually plan for the future of your healthcare. So thank you guys for listening to this long-winded conversation. If you do have any questions, again, my contact information, and if you are interested in learning more, my contact information is 970-829-4804, extension 103. Or you can always email me at john@altiuspt.com. All right. Thank you so much, and hope you enjoyed the presentation.